All right, I think we're going to go ahead and get started. So hello, everybody. Welcome. Thank you so much for joining us today. So this month, Fireside Chat is in honor and recognition of Cervical Cancer Awareness Month. And so the Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. So the Office of Community Outreach and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota. And Kiara, do you actually want to go to our team slide? Thank you. So our team's mission is to reduce the burden of cancer in Minnesota by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, treatment, survivorship, and clinical research opportunities. So my name is Amna Hussein. I am the Community Engagement Coordinator on our team. And so thank you all so much for joining us for this very important discussion. Cervical cancer is one of the most preventable forms of cancer with appropriate screening and vaccination, and it is treatable if detected early. So a cervical cancer-free future is possible. And so today we are joined by gynecologic oncologist, Dr. Rahel Ghebre. Dr. Rahel Ghebre wears many hats, both locally and internationally. And so if you actually go to the next slide, Kiara. So on this slide, just a few of some of the hats that she wears locally. So Dr. Rahel Ghebre gained her medical degree from the University of Michigan and her Master of Public Health from Johns Hopkins Bloomberg School of Public Health. She is an expert in surgical and medical management of women diagnosed with ovarian, endometrial, cervical, vulvar, and vaginal cancers. Dr. Ghebre is an internationally recognized educator in gynecologic oncology and received the 2020 International Gynecologic Cancer Society Award for Excellence in Training. Let's all give her a round of applause for that. She serves as a chair for gynecology oncology special interest group under the African Organization for Research and Training in Cancer. She is a member of the National Comprehensive Cancer Network's Harmonized Guideline Committee for Sub-Saharan Africa. She is also a part of the ASCO Resource Stratified Guideline under the African Cancer Coalition, which is an initiative that is supported by the American Cancer Society. Her research is focused on improving cancer care for women with gynecologic cancers in the US and globally by increasing access to quality care and clinical trials. We are so honored to have her join us today for a conversation on cervical cancer and the role of regular Pap tests and the HPV vaccine in cervical cancer prevention. So we will be recording today's session so that you can refer back to it on our YouTube page. We will edit out every recording before we post it to ensure your privacy. If you are now just joining us, please take a moment to locate the mute and unmute button, as well as the chat button, because during today's presentation, please use the chat box to submit your comments and questions, or you can send them directly to me. Following Dr. Ghebre's presentation, she will be available to answer questions. So at that time, if you want to, you can unmute yourself to ask questions. All right, so I feel like I just spoke a lot at you. So Dr. Ghebre, please take it away, and please all help me warmly welcome Dr. Rahel Ghebre.
Thank you. I have to say I'm quite honored that each and every one of you took some time this afternoon to listen to a topic that I think is important to women, and hopefully you feel like there's some value in our conversation today. So I'm going to go ahead and just introduce the topic generally with some of the information that I know you probably already are aware of, but really want to get to your questions so that we can have a moment for an open conversation. And I like the fireside chat. I feel like there's a fire missing in that process, but the concept is fantastic. So I'm going to go ahead and share my screen. Excellent. So this will be a short overview discussing, what is the option for cervical cancer prevention and the focus on HPV vaccine. We'll talk a little bit about cervical cancer screening options as well. I know that the options seem to be getting more complex and certainly are harder to keep up with as the guidelines change. And then we'll talk a little bit about just highlighting what the typical symptoms might be, understanding not every woman will have all the symptoms when they present for cervical cancer. So, as you know, that our goal really is to prevent cervical cancer. So this is a fantastic image that talks about there's a pathway towards that. That's sort of both at the younger age group, which is focused on vaccination, and then the older age group, which is transitioning to the screening pathway. Ultimately, the screening really should lead to the next step, which is a closer look at the cervix. That process is called a colposcopy. So women are often asked to return for a secondary assessment. So the screening is just a way to pick up what might be a signal of abnormality. It needs to really be confirmed by colposcopy, and that is done with a trained healthcare provider, and then that ultimately may result in obtaining a tissue biopsy, and absolutely must be followed with a treatment plan. And it's ultimately the close follow-up that prevents the occurrence of cancer. So to give your attention just to this map, and a lot of the work that I do is globally, because cervical cancer is a global problem. So this is a most recent map that looks at the distribution of cervical cancer incidence in 2020. So you can see on the far left-hand side at the bottom are really what are the rates per 100,000 of the population. And the more dense the color is, the higher incidence that we see of cervical cancer. So certainly in sub-Saharan Africa, there's a larger proportion of population that's getting cancer of the cervix, as well as other pockets across the world. But what is not captured in this map is that even within the US, we have populations who have increased risks. And so when you look at the whole US map, it looks like we fall under the lowest subcategory for risk factors. But we have population of women who continue to be at increased risks. So our work in the US is really much more engaging communities who are at increased risks, as well as women who are currently not undergoing the standard screening guidelines. We have globally risen up to make a commitment. Let's see. I think my screen is jumping. Are you seeing the next screen?
It's on the cervical cancer
Yeah.
slide.
I don't know why it moved. But anyway, the prior screen was looking at the WHO commitment, including nations across the US, talking about a plan to eliminate cervical cancer. So we are definitely moving beyond just preventing cervical cancer towards eliminating cervical cancer. And that is a much more concentrated effort on getting our vaccination rates up. So not all countries currently have incorporated the HPV vaccine into their screening national guidelines, or sorry, into the vaccination national guidelines. And there are lots of different reasons why that is the case. We're lucky to have that as part of our national guideline, but ultimately eliminating cervical cancer globally is about getting more and more of our both girls and boys vaccinated. And then, of course, increasing the screening population. So this looks just quickly at what the anatomy looks like. You might be used to looking at the anatomy of the uterus. So this is the uterus here. That's a uterine tissue with the muscle. And then the very bottom portion of it is considered the cervix. And that, of course, leads out to the vagina. So the cervix does have a length to it, on average, 3 to 4 centimeters. And when we're talking about cervical cancer, we're talking about cancer that occurs in this tissue. This is then magnified. If you see this little small box that then pulls out to look at what the microscopic would look like. So the normal tissue of the cervix has this epithelium layer that then leads to this more muscular tissue where vessels and lymphatics sit. So the HPV infection upon contact infects the epithelial cells. And the epithelial cells also exist along the vagina and the outer skin of the vulva. So that's why you can have multiple sites for the HPV infection. But over the time, as it interacts with the immune system, there are subset of persons who have the capacity and do clear the HPV infection, and then others for many different reasons who have a persistence. And we have an understanding that the persistence might be years in progression, but ultimately there are cellular changes that occur that then lead to these grades of what we call cervical intraepithelial neoplasia. So grades of changes of severity within the cell. So ultimately, though, what really defines cancer is that the abnormality that sits in this epithelial layer, the cells acquire the characteristics that allows them to break this very important wall. It's called a basement membrane, but what is important is that that layer separates these cancerous cells from some critical tissue like the vasculature and lymphatics. So cancer, by definition, cervical cancer means cancerous cells that are present in the epithelium and can be now detected in the deeper tissue. So when the doctor is looking in to evaluate the abnormality, he or she is, of course, looking into this tissue with greater magnification. And when they take a biopsy, they're trying to really get a tissue that the pathologist can break down and categorize where the level of abnormality is. There's definitely, a progression of that. And that's where screening really can make a difference, because we have multiple opportunities to intervene along this pathway of progression. So it seems to want to give me a hard time. I'm going to stop sharing and maybe, no. I'm going to reshare that and hope that that will get that fixed. The world of Zoom. All right, going to just go through them quickly. And that's where we're at. This fantastic image looks at what the infection with the HPV infection looks like over the course of the lifetime of the person. So in this case, we're thinking about, here's the age in years, and then this is sort of the population prevalence. So here's, a normal, not exposed to HPV. And then as the person ages, and primarily as they have exposure through sexual contact, we begin to see that the HPV infection rates increase. But over time, we do clear that. So a majority of us go on to clear that. But then a subset, as that HPV lingers in the tissue, it then can progress into this precancer category. And again, we see a rise and a peak with time, and that kind of, eases. So some of the precancers, again, the immune system is able to clear, not all of them. But then you can see that the cancer rises actually are pretty low in the 20s and really are slowly increasing, and they continue to increase slightly peaking somewhere here in the 40s to 50s. But the onset of the cancer is lagging by a decade or more from the actual infection rates. So that might help you to think about why does screening start, in the 20s and not earlier? And what does it mean if you have an HPV infection early in the 20s, but the doctor says, let's just continue following it, because there is an expectation that that you might be in the subgroup that will go on to clear that. So I'm going to just highlight what are the current recommendations for the HPV vaccine schedule and dosing. Again, these have changed over time to become a little bit more simplified, I think. So the vaccination can be started as early as 9 years, but recommended start between 11 to 12. And the recommendation is that if the vaccination occurs before the age of 15, 2 doses are required. So CDC recommends 2 doses of vaccinations for all adolescents at age 11 or 12 years. And that's for all genders. And then catch-up vaccinations can occur after that age. If the vaccination starts after 15, though, because of the difference in the immune reaction, the recommendation is to do 3 doses. There occasionally can be indications for when a person might go on to have a vaccination after the age of 27. It's not a very common occurrence, but there might be some select cases. By age 27, because there's already been an exposure to HPV, most commonly, at that point, the benefit decreases. And so that's why the cutoff is currently at age 26 for vaccination. So the cervical cancer screening guidelines, these are the ones that I've put, I think are, talk about maybe the most option under the US Preventive Task Force. But the American Cancer Society most recently published guidelines that I think are pushing that forefront a little bit. So we can think about the vaccination. The screening would start, according to the guidelines from the US Preventive Task Force, somewhere around 21. And then for that first timeline, we understand that the HPV might be present and not signal pre-cancer changes. So the recommendation is to do cytology only, so that we're picking up only changes at the cellular level rather than just detecting the HPV. The American Cancer Society in their guideline, though, are moving towards much more HPV-driven testing. And so their recommendation says start with HPV screening-based testing right away at age 25. So they think that the benefit is minimal for screening below age 25. Again, going back to the US Preventive Task Force, for women above 30, though, now we begin to couple the HPV with it. So the most common combination that I see is that women are getting cytology testing in addition to HPV. So it's this latter part, which is every 5 years, getting the high-risk HPV testing in combination with cytology. I think the most important part is to have a screening done. So maybe it's not as critical to have a very specific, but any screening is better than no screening. And then once you're on a schedule, continue to follow that schedule. So what are the cervical cancer symptoms? The most important part to remember is by the time that women have symptoms, we've missed a window where we really have the best outcome to either treat it in a precancer stage or it's early and it is highly cured. So nevertheless, yes, we do encounter women with cervical cancer, and some of the symptoms can be difficult to differentiate from other gynecologic symptoms like abnormal discharge, bleeding that can be irregular, and it can be considered to be for many different reasons. So it can be confusing. But then ultimately, as it progresses and affects the tissue in the nearby region, women will begin to report pelvic pain, pain with postcoital bleeding. And then as it begins to advance, then there's some very significant pain that can occur: pelvic pain, lower back pain, nerve dysfunction. So it is definitely a difficult disease as it advances to manage. This is a busy slide, but I do think it would be worthwhile to look at it. So I'm going to just give you attention here. This is the most recently published data from cancer that looks at many of the different kind of cancers that women encounter. So this is in 1930s, and you can see over time, certain cancers certainly have changed. Let me just elevate it here. So again, for example, if we look, the red happens to be lung cancer. Very low rates in the 1930s, and then as smoking rates increases, lung cancer begins to rise. And we've done a much better job at controlling tobacco exposure, and indeed it is decreasing. But then the purple line is actually a combination of the uterus cancer and cervix combined in this one. And so it was much higher, and we have done a much better job reducing it with screening methods for cervical cancer in particular. But this one pulls it out to say that the rates, though, seem to be slightly on the uptick most recently. That actually is reflective of increasing rates of cancer of the uterus rather than the cervix. But overall, if you look at it globally, and you follow this purple line, you can see that over time, screening really has done an important contribution to us being able to control cervical cancer. So today we're doing better than we've ever done. So in conclusion, I want to just mention how important it is to get the HPV vaccine. It is the most effective way to prevent cervical cancer. And then persons who really, who do not undergo cervical cancer, wherever they live, in whatever setting, continue to be at high risk for cervical cancer. So we're going to stop there, and I'm going to stop sharing so that you'll have a chance to have that chat that we really wanted.
Yes, all right. Thank you so much, Dr. Ghebre. So are there any questions from our viewers today? We had quite a few questions come in through the registration, but I want to kind of open the floor up to any of our attendees. While those come through, if anyone wants to unmute yourself, feel free to do that. But to start, so have you seen any like an increase in vaccine reluctance for HPV, kind of given the times that we're in now with the vaccine hesitancy and reluctance that we've been seeing with the COVID-19 vaccine?
I have not seen a specific publication that has highlighted that. We do get annual updates on vaccination uptake in adolescent, and the numbers from 2019 to 2020 looked better than they were. So about 75% of age eligible adolescents have received at least one dose, and I think something a little bit under 60 have completed all recommended doses. So my impression is that that we are doing the same and maybe slightly better, but I can't confirm with you. It is certainly plausible. It's very plausible. And as is often the case, there are differences depending on the geographic location and characteristics of the community. So probably we'll need to go deeper into that data. But great.
Awesome. Thank you so much. Okay, so in the chat here, there's a question about what are your thoughts on primary screening?
So I am going to assume primary screening means just cervical cancer screening rather than, so yeah, we get a little bit technical with those words, right? They can get confusing. So we use the word primary in the setting of prevention because it means primary as if you've never had it before, the HPV. And then a secondary prevention, we'll talk about that as a screening. But if you mean primary screening as an HPV only based primary screening, it is certainly being, there's just a lot more data on that. And it is one of the options currently available under the guidelines is just to go with HPV without the cytology. Not sure if I answered the question, but I hope I did.
Thank Thank you for that. Okay, so we have time for just about 2 questions here. So is it okay to stop cervical cancer screening after repeated negative tests?
Well, that depends on your age and if you've had any cervical abnormality in the past. So it's not an automatic yes. If it helps, I can stay a little bit longer to allow everyone to have a chance to answer it, to get their questions answered.
Okay, awesome. Thank you so much for that. Okay, so that's great. So next question is, how long has the HPV vaccine been around?
I can't recall exactly when it was approved. There were a significant number of studies done that led up to it. I want to say it's probably been at least 12 to 15 years, but correct me if I'm wrong.
But then, I mean, a lot of incredible data has come out from it about how safe and effective it is. So it looks like another question is, if you had cervical cancer and your cervix was removed, how does screening continue, or is it even necessary? Great question.
Yeah, so if you've had cervical cancer, then you are in a subgroup of women who require follow-up, and the follow-up depends on what kind of treatment you've had. And so if your cervix has been removed, you actually do need to continue to be, I don't want to say the word screen, but you need to have follow-up to make sure no new problems show up. So if you remember that HPV, it can affect the vagina, it can affect the outer part of the skin called the vulva. So you and your healthcare provider will work up on a schedule on continued follow-up. So you do need follow-up. But not necessarily screening per se, but to make sure that no new problems come up.
Thank you so much. Okay, so what is the protocol after having one leap? Are they still doing multiple before moving to surgery?
Yeah, so the purpose of a leap is to remove a part of that cervix that might have the disease involved in it. So at that point, we're thinking it has a precancer in it. So then once that tissue is removed, it needs to undergo certain testing. So we need to find out what degree of abnormality is it? Is the full area removed? Was there areas that were suspicious for cancer, or kind of a high level of precancer? And then, of course, it's always about the person. Who is the person? Have they had children? Do they want to have children in the future? So then it gets to be complex. So it's sometimes women over their lifetime will have had more than one leap, and other time they'll have had one leap, and because of the factors of the tissue will go on to have a hysterectomy, or sometimes they'll have one leap and never again. So it can vary, but it's a really good question.
Okay, are there any other questions from any of our viewers today? Because I have one that I really want to ask you that came in through the registration. Okay, so I'll go to that question. So there has been a lot of buzz about new screening options. I know that you mentioned that the American Cancer Society is kind of focused on HPV screening. So what are your thoughts on the vaginal self-testing for HPV infection and promoting them? And then how would you engage or anticipate to engage with hard to reach populations on screening rates?
Yeah. So the HPV opens up different ways of doing the testing. If the reason that women might not be undergoing testing is because they have reluctance to actually go through that exam, or they're in settings where there's not really a large healthcare providers who can do that, for them. So HPV testing where the woman herself collects a sample, I think is very, very reasonable and will likely be very successful. Of course, the testing is not going to be very helpful unless you can then do the next step, which is follow up the abnormality and get the person into the clinic. So I think the challenge right now is making sure that we do the studies well so that we know exactly in what settings work. And sometimes what we think will work to increase access, we find out it doesn't really work. If there's not a knowledge and awareness, you can offer all different kinds of options, but it's still not going to have the appropriate uptake. So it's exciting. We currently have an open clinical trial on that in communities, but I think there's more to come. I have no doubt that it will be part of our long-term plan for cervical cancer screening. I'm certain it will somehow get incorporated at some point.
That's great to hear. Thank you. Okay, so one more question. So should a woman still have Paps if the cervix was removed and also a hysterectomy was performed?
So the guidelines say that if the reason that surgery was performed was because of a precancer of the cervix, then she'll need to continue to have follow-up, which getting a Pap of the vagina might or might not be part of it. So it's probably the reason as to why the hysterectomy was done. But let's say, for example, a hysterectomy was done and that person never had any abnormalities of like its HPV effects ever, no cervical dysplasia, then at that point, they likely would not need any more screening.
Thank you so much all for your questions. So I do kind of want to wrap up here, unfortunately, just because we are over time. But thank you so much, Dr. Ghebre, for just taking the time to speak to us, to join us, and then also just for going over time because you are very, very busy. And thank you all for just the engaging discussion on cervical cancer. It's very important. And so we hope that you all kind of learned from the session today. So you will receive an email shortly following today's session with just a link to complete a quick survey. Please fill it out because again, it will help us continuously improve the fireside chat and bring you what you want to hear. And then also if you complete it, you will be entered to win a swag bag filled with Masonic Cancer Center goodies. And then also the Amazon e-gift cards will be sent out to all attendees today, probably by next week. And then also feel free to follow us on all our social media accounts. So follow the Masonic Cancer Center just to stay up to date on what the Office of Community Outreach and Engagement is doing. And then also just for future announcements and fireside chats. So again, thank you everyone for joining us today. We hope to see you in the future. Take care, everyone.
Thank you. Have a good day.
Thank you.